Thank you.
introduce our next that we can introduce our next speaker, Dr. Vidhya Thobbi. While Ganesh is sharing screen, I will just mention that she is the president-elect of Kasoga. She is also a governing council member of ICOG. She's been a past chair for the Foxy Food Drug Medico Surgical Equipment Committee. We've done a lot of work together in the past. We've also done a lot of events together in the past. She has, I think, started work on something like a drug directory, which we hope will be published soon. Maybe when she takes over as the president of Kasoga, I would request Dr. Bhagyalakshmi Naik to please formally introduce our speaker.
Yeah. Thank you so much, Dr. Pratik, for giving me this opportunity. I think I learned a lot about carbetocin from Madam's talk. So it's really a pleasure introducing Dr. Vidhya. I think she's a very, very close friend of mine in Foxy. And can you share her CV, please? I think formally I have to read out what all is there in that, but as Dr. Pratik has already mentioned that she was the chairperson of Food Drugs and Medico Surgical Equipment Committee and has done a wonderful work and has got awards for that also. And that this is the Best Committee Foxy Award, Meru Dara Hansotia Award for 2020. She is an ICOG Governing Council member, Foxy Champion Award in 2019. And she is the National Corresponding Editor, Jogi, President, Bijapur OBGYN Society, has been the secretary, Bijapur OBGYN Society, has 2007. She has publications in various books and contribution to many chapters, has been in Foxy Focus, and has been speaker at national and international conferences. And I think she's also advisory faculty of boards in Rajiv Gandhi University and is a postgraduate and undergraduate teacher for the last 30 years. So I think she will be the best person because she has worked in so many areas that she'll be the best person to tell us about surgical management. And I think always, as we have heard from Dr. Leela, it's always prevention is better than cure. But sometimes I think carbetocin will really fail you and you will need some kind of surgical intervention. And I think it will be lovely to hear from you, Dr. Vidhya.
Thank you very much, Bhagyalakshmi. It is really nice to hear from you always, and always there are so many stalwarts on the dais now to share their experiences, and it is again a pleasure to share my screen as well as share my views on surgical management. And amongst, as I tell always, that it is like my Maheri, what I talk in Marathi, that it is always for my pleasure to share my views on this. So hope my screen is visible.
Yes, ma'am, you can go full screen, please.
Yeah. So thank you amongst and amongst endocrinology committee. And as I always tell that always it is very great to talk on this subject and talk on the dais of amongst and the stalwarts. Thank you, Dr. Rajendra Singh Pardesi, Dr. Sujata Dalvi, and ICOJ office bearers, Dr. Lakshmi and Dr. Ashok Kumar. Of course, Kiran is not there, but Kiran is also a very good friend of mine. So thank you, Pratik, to call me on this topic. And I think you will be better person to be expert on this topic because Mumbai, always we say that there are many tertiary cares and many complicated cases you people handle. Of course, in the medical college, we also do, but the amount of the burden we get everywhere is different. This is always...
Sorry to interrupt.
Yeah.
Sorry to interrupt. Can you stop screen share and reshare again?
What happened?
Because it's not seen properly. Your slide share is not being seen.
Oh my God. What has happened?
Nothing. You can just stop and reshare. Usually that fixes the issue.
Not tech savvy like you, Pratik, but anyway, I will stop. Is it visible?
Yeah, can you go full screen now, please? No, it's not working. I think you present it without full screen. That will be better.
Without full screen?
Yeah, without full screen will be better because your screen is not being seen properly.
Mm. Now, any problems?
It's okay, ma'am. You can go ahead.
But I'm not able to see it full screen now. Is it visible now, Pratik?
It's visible, but only part of the slide is seen. That is the issue. The full
Oh,
slide is not seen.
acha. Something is wrong with the.
No worries. You can go ahead and speak.
Yeah.
This is okay. This is okay. This is fine. Don't go full screen. It's fine. Just present.
Yeah. So this is famous what Fortala said about the woman. Women are not dying because of the disease we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving. So the decision making, whenever we talk, where to stop for the medical management and where to start surgical management is very, very difficult and different. Now also it is not seen.
We can see a slide which says action plan for management of PPH. I think that's your 9th slide.
Dr. Vidya, are you sharing again? You're muted. Yeah, I think now you can make it full screen.
Is it okay?
Yes, ma'am. That's fine. Please go ahead.
Perfectly okay, Dr. Vidya.
Oh, thank you very much. Okay, so we talked all about incidents and everything, and just I was talking about the decision making. So most important decision is when to reinforce the medical management with surgical management to save the life of the mother. So when to stop or when to additionally work on surgical management is very difficult decision, but it is very important decision for the saving of the life of the mother. Because if you don't take proper decision at a proper time, the lethal quad of PPH ensues, that is acidosis, electrolyte abnormalities, coagulopathy, and hypothermia. We always talk of bundle approach, and this bundle approach is very important, which we always I don't know what has happened. It is not moving. My slides are not moving now.
No, your slides are not moving. They are not on full screen also. You can stop
Madam, what you
sharing,
can
share
do,
again.
what you can do is you can email me the presentation. I will share again, just like
That
for
is
Dr.
the right
Leela.
thing. Yeah. But you told me that you
Unless you
I
have
made
videos
it
which
the
cannot be
30.
emailed.
Otherwise, no, your screen is minimal. Yeah, you can.
I have now I can talk like this. Okay.
Yes, this is
I
fine.
can't see that.
This is fine, ma'am. Please go ahead.
थोड़ा-सा
Yes.
वाढवा, slightly.
नाही मी ते
You just enlarge a bit.
You can
Slides,
enlarge
you just
a bit.
have to
Dr.
enlarge them a bit and it will be fine. Yeah, I think this should be okay. No, this is
Hmm.
more. Yes, this is perfect.
this is center.
Perfect. Go ahead.
Okay, this is so I was talking about the bundle approach in PPH. That is a comprehensive approach for the management of PPH, which always considers all the areas from the root to roof and all aspects which may lead to PPH unless taken care. So it includes what we talked of prevention and curative aspects. So here you can see the surgery referral comes at the last end. But you have to always think of these things, like these are leadership, data, monitoring, quality improvement, respectful maternity care. But the PPH emergency response rotates on all this bundle approach. Now, we talk of action plan of management of PPH, that is hemostasis. And I would like to talk from this stasis, that is a specific surgical management of PPH. So that's what we focus on, that is shift, then think of tissue, trauma and tamponade first, then compression, systemic devascularization and interventional radiology, and lastly, but most important, is a hysterectomy. So this approach covers all the surgical management of PPH. But I'm not going to talk of tamponade, tissue, and little bit of trauma I have included in some of my slides. So what about the newer development in the therapeutic options? The type of surgical intervention depends on several factors. And most important, we always talk of experience of the surgeon. If surgeon is not experienced of any of these procedures, better to shift to tertiary care center. The other factors, of course, for whenever we take the decision is about the parity, desire of future children, the extent of hemorrhage, general condition, of course, and the place of confinement. So if the facilities of blood transfusion or any ICU, HDU is not available, then we have to bring down our whatever the management options are available, like periphery. Then stitch in time saves 9, and traumatic PPH always the bleeders have to be stopped. But what about atonic PPH? When the medical management fails, then we think of these surgical interventions like compression sutures, stepwise devascularization, and hysterectomy. So first, always we talk of compression sutures, and we know the great person, that is B. Lynch. Now, this B. Lynch, which was performed and described by Christopher B. Lynch, and I had an occasion to meet him once or twice, and he demonstrated various modification also and his own technique. So long back in 1989, he developed this when the patient refused a consent for emergency hysterectomy. So consent part is also important whenever we do any surgical interventions. Now, these are the compression sutures which are applied over the atonic uterus in various patterns, upper segment, lower segment, both, and it acts as a brace to facilitate uterine contractions and retractions, similar to effect produced by manual compression of the uterus. So it always stops the bleeding from the placenta side because it opposes the anterior and posterior uterine walls together. So patient positioning is very, very important. Never take the position on the left side. Why the right side, that is Lloyd Davis position? Because we have to see that this compression sutures which we are putting, it is effective, because we have to see any bleeding through vagina or any other exposure. Any traumatic is also there in lower part. So the positioning is very important. And always there is 10 principles we should remember, that is Lloyd Davis position. You have to exteriorize the uterus. Basic surgical competence is required for putting these sutures. So we have to find out various skill drills. Perform bimanual compression first, and take a transverse lower segment incision in the standard Billin suture. Uterine cavity should be checked, explored, and evacuated. Sometimes we find some adherent placenta or additional placental lobes, and also you have to always check the uterine cavity. You should explore it and evacuate it. And what are the advantages? This compression technique, it allows the free drainage of blood and always checks the bleeding control any vaginally, including any you have to swab and find out any things inside. The suture material which is used should be strong, absorbable, like Vicryl number 1, monocryl, or chromic catgut even number 2. The needle length should be proper, that is at least 70 to 80 millimeters, curved needle, and 8 to 10 centimeters for straight needle. So straight needles are also available nowadays. This is a standard procedure we all know here. I don't know whether my pointer is seen, but we know we have to enter 70 millimeters round body hand needle should be taken. You should enter 3 centimeter here. You can see here 3 centimeter from below the low segment. Enter inside, come out the 4 centimeter from the incision, and then go round, come posteriorly, enter the posterior segment, then come out 4 centimeter, go round, and then tie, and then you have to suture the low segment completely. Now here, properly you should compress the uterus anterior posterior and see that it works. Otherwise, just putting the sutures loosely won't help. So somebody has to compress the uterus from both the sides and tighten it. So it is very useful. So many studies are available on B-Lynch, and the tension should be even. So if you put the proper tension, there is no ischemia and no necrosis. Some people are worried that with the B-Lynch there will be necrosis, but I have put so many, I have not found a case, but there are some of the case reports which are available in the literature. Now, some people, they feel that after some days, these sutures, they will fall down, and sometimes entanglements of intestine or something may happen. So some people are fond of taking the additional bites at the fundus, but I think that is not required as such, because as the sutures, as the involution takes place, the sutures also may become loose, I agree, but I have not found any adhesions or anything of these B-Lynch sutures. Now, this is one of the pictures of B-Lynch. What I could not incorporate the videos. I had told Pratik actually I would send those, but I could not do those. So this is one of the case where the B-Lynch suture is placed. Now, what are the modifications? These are the modified B-Lynch procedure, because they never wanted in normal deliveries. If you want, if the PPH is there, if you want to put B-Lynch, again, you have to open the low segment. So they modified this by Dr. Heyman and of course, our Professor Arul Kumaran. There is no lower uterine segment incision here. Additionally, you can put 2 cervicoischemic sutures also. So cavity is not open. The uterine cavity is not explored, of course, if anything is there, because it is not, even though it is under direct vision, we are not opening it. Quicker to apply and no feedback data for to slippage of the sutures. I was talking of that is the shouldering with the venous obstruction. That is 1 or 2 cases are reported with this. Now, this is a cervicoischemic sutures. If there is a bleeding in the lower segment, which can be arrested by applying this ischemic cervical opposition sutures, which occludes the placental blood vessels by the apposition of anterior and the posterior wall. So, this is how the cervicoischemic sutures are taken. These are again different sutures, like we know these Cho sutures. The straight needle is passed through the bleeding sites to compress the endometrial cavity. Firstly, passed through the anterior to posterior walls, 2 to 3 centimeters laterally. The needle is passed back to the posterior, then anterior wall, and it is moved 2 to 3 centimeters upwards. And the same procedure is repeated in the opposite direction. So knot is tied as tightly as possible, and there is a square suture which is completed. So multiple squared suture, Cho suture can be used for the uterine atony. So this is how it is taken from posterior to anterior, then come posterior. So it looks like a square. So 4 square sutures can be put, but it requires big needles, and maybe the straight needles would be useful. I have not put any time the Cho sutures. I am happy with the Billin sutures. So here what happens is the uterine cavity drainage, there is a restriction. So there is always a risk of pyometra, and there is again no feedback data on fertility outcomes. Morbidity feedback or data is also limited. So rhythmic contractions, when it happens, it is not facilitated, and so subinvolution. So involution is impeded, of course, and there is a subinvolution. So these are various compression sutures. I must mention Dr. Gunachila. She had done this circular sutures, compression sutures. But there are 2 to 3 reports with this Gunachila stitch, circular stitch of the necrosis. So these are the few things. And there are other sutures also, which because of paucity of time, I have not mentioned, but I have added in my presentation. Lastly, I can show them. Combined applications like uterine sandwich techniques also have been tried. So Billin suture can be useful in this way because the use of balloon tamponade, it decreases further bleeding. There is a compression inside. Then you apply for the compression suture and you put a balloon inside. The Billin technique is the only uterine compression suture which does not occlude the uterine cavity. So it can be used in combination with the intrauterine balloon. So there are various reports in the literature that the success rate of these compression sutures, which is around 92%, they are effective method for the treatment of PPH. So they avoid hysterectomy and they do preserve the potential fertility. One more report, they have done prophylactic compression sutures in cases of over-distended uterus, like delivery of the twins, and they have found that the success rate is 98.6. So if you suspect that these patients are going for atonic PPH, so they have put Billin sutures in such patients. This one can be even this twins, then over distension in polyhydramnios. Also, they have done. I have seen some of the studies where they found that in all over distended uterus, by any means, they have tried this compression sutures. So overall literature, if you see the overall literature, the hemostatic sutures in arresting PPH and preventing hysterectomy is around 75 to 90%. So they must be used within 1 hour of the delivery, and the chances of success rate are around 85%. So apart from effective, these sutures are very simple. They preserve the menstrual function and fertility. Why they fail sometimes? So one is wrong technique, delayed application, and no intraoperative testism. Means once atonic PPH, you have to compress and see that whether this compression helps. And sometimes additional factors like DIC. In these patients, there is a failure. What about the complications? There are no large published data, but small observational studies and case reports, they show these complications. The short-term complications, they are either cut through, then hematometra, pyometra, or partial and complete uterine wall necrosis due to ischemia, and long-term consequences, as I was talking of bowel herniation, intestinal obstruction, and some of the few cases of Asherman syndrome. Now, the third one is we talk of systematic pelvic devascularization. So this is always a rescue surgery, and ligation of uterine artery and ovarian artery comes the first. The sequencing is unilateral uterine artery ligation, then comes bilateral uterine artery ligation, ligation of descending branch of uterine artery bilaterally, then ligation of unilateral utero-ovarian anastomosis, and ligation of bilateral utero-ovarian anastomosis. So this is a nice picture we show the ligation of the uterines, then utero-ovarian anastomosis, all both the sides, so bilateral. So this is always a stepwise, and it is very, very successful. As we know, the uterus is richly supplied by these blood vessels. But this is a first line of treatment to control PPH at the time of cesarean delivery, of course, and it has got a more than 95% of the success rate. Most useful when hemorrhage is of moderate degree and originates mainly from the lower uterine segment. So we know that the uterine artery forms about 90% of the blood supply of the uterus. It increases twice in the size, and it runs upwards from the isthmus and enters the uterus and gives us so many branches. But the most important is ascending and descending branch. Now these uterines may split into 2 to 3 branches before they enter the uterus. So uterine artery ligation should be successful. More than one ligature might be required. You can see here, so uterus is so much richly supplied by these uterine artery and its branches. So one must tie once or twice. The procedure is very simple. It is done below the transverse incision or 3 centimeter below the loose attachment or UV fold in case of vaginal delivery. So you have to just separate the UV fold. You have to put 4 fingers behind one hand, and you should elevate the uterus. And you have to prick at the avascular zone of the Brad ligament when it is UV visualized. The suture commonly we use is Vicryl 1 or catgut number 2, and it should be passed 2 to 3 centimeter medial to the uterine vessels, and some part of myometrium is to be taken, and it has to be taken laterally from the avascular zone of broad ligament and tight. If not controlled, then same procedure you should follow on the opposite side. So this is just a pictorial demonstration or pictorial picture of showing the uterine artery which is tight on the right side. Here you can see that these are the vessels you can stepwise you can try. Here's the uterine, then ovarian anastomosis. Here you can just below the fallopian tube, and it should be usually unilateral, does not suffice, so you have to tie on both the sides. These are the steps we all know, so I will not repeat the steps. The steps are the same on both the sides. This is a lateral picture. You can see the anatomy and the relations, and how it has to follow the stepwise. So I just put, and this is, you can see here nicely the uterine exposed, and how it has to be, the uterine myometrium has to be included whenever we are ligating the uterine artery. So you have to tie one up and one descending also, both. So, and this is very important, that is a cervico-ischemic sutures and the uterine artery ligation. When these are, whenever there is a placental bed bleeding, you have to take some circular sutures on the placental bed. Along with that, you have to tie the cervico-ischemic sutures and uterine artery ligation. So 10 to 15% of the bleeding will stop with uterine artery ligation, and 70 to 90% it will when you do this on the both the sides during pregnancy, because the 90% of the blood supplies from the uterine artery. So this is a famous study. We all know that he had studied about this. Abdo-Rabo studied around 103 cases, and he saw that it is 100% of the success rate. And 85% of the patients, they responded to the bilateral uterine vessel ligation, and only meager of the cases required the ligation of the utero-ovarian anastomosis. Now, what complication can occur whenever you are doing this uterine artery ligation? Bladder injury, ureteric injury, bowel injury, and broad ligament hematoma if you puncture it. That is most common with this uterine artery ligation. Now, what about internal iliac ligation? So it is always indicated before or after hysterectomy for PPH. Continuous bleeding from broad ligament base, profuse bleeding from the pelvic side wall or vaginal angle, or diffuse bleeding without clearly identifiable vascular bed, or ruptured uterus when the uterine artery may not be torn at origin, may be torn, this side and that side, we will not able to know where it has so much. There is a broad ligament hematoma, and we don't find its origin from where it is torn. Here we have to ligate the internal iliac ligation. Where the extensive laceration of cervix have occurred following difficult instrumental delivery. In these patients, definitely internal iliac artery ligation helps. And just a few lines about the anatomy. We all know, but just it is a repetition. The abdominal aorta bifurcates right and left common iliac at the level of L4 and divides at the sacroiliac joint into external and internal internal iliac arteries. And the external iliac, as all of us know, that is a principal artery for the lower limb. Internal iliac again provides the principal supply to the walls, viscera of the pelvis, and the perineum and the gluteal region. This is very important. These are the important relation of the internal iliac artery: anteriorly ureter, ovary, femoral end of the fallopian tube, and posteriorly we can see that internal iliac vein, lumbosacral trunk, sacroiliac joint, laterally external iliac vein between the artery and psoas major, inferiorly obturator nerve, and medially the parietal peritoneum. These are the important relations we always should remember whenever we are ligating internal iliac artery. And this I just showed you, anterior division and posterior division. We always talk of anterior division. There are parietal and visceral branches. Why I was talking about the visceral branch here is supply, that is a visceral branch gives rise to superior vesicle, uterine, inferior vesicle, middle, rectal, and vaginal. Now, this vaginal artery is a direct branch of internal iliac, and many times we see that there is a colporaxis, and even sometimes I have seen the hysterectomy is done, still it bleeds. So in these patients, definitely it helps the anterior iliac artery ligation. So these are the various branches one should remember about the internal iliac ligation, and as well as the various relations. And it is very life-saving procedure. All of us should learn and teach our students. And Kelly, who 1983 was the first person to perform for uterine cancer, and later it was popularized by Mengert and Burchell. Then this is a popular question we always ask to our students, that how it helps. Now, what happens is the pulse pressure in the artery just distal to the point of ligation decreases significantly. And second thing is, when both the arteries are ligated, the pulse pressure even still decreases by 85%. And this reduction allows the blood clot to form at the site of bleeding from the damaged vessel. And the blood flow distal is also decreased by 48%. So ligation converts, this is the most important, is into arterial system, into the venous system, leading to the stable clot formation. And so it causes hemostasis. The procedure, there is anterior or lateral approach and the posterior approach. So that is, one is through the round ligament and the second one is from the pouch of Douglas. So this is how we ligate, and this is a picture how it is ligated. Now, about the round ligament of the lateral approach, after opening the abdomen, the uterus is eventrated and the round ligament and the fallopian tube is identified, and 5 centimeter incision is made on the peritoneum between them. Then you have to enter the retroperitoneal space, which is very important, and that should be dissected bluntly with the fingers. The ureter always remains to the medial fold of the peritoneum and quite away from the vessel. That is very important. And directly one will be over the division of the artery with the little dissection. The adipose tissue, you can clearly see here the adipose and lymphatic tissue over the internal iliac artery, which is dissected with the caudal movement. What they say is the mixture should be passed from the lateral to the medial. That should be 3 to 4 centimeter away from the division beneath the internal iliac artery with a non-absorbable or absorbable suture, and this prevents injury to the external iliac vein. This is very common complication, and we faced this once, the injury to the external iliac vein. Then we had to call the surgeon who is the oncosurgeon, and then they tied this vein. It took around 3 to 4 hours to get the proper hemostasis done. They ligate the vessel with the 3 knots, palpate the femoral artery. This is very important. Otherwise, if you are tied the external iliac, then the femoral artery pulsation will not be there. Ensure the perfect hemostasis. Keep the drain for 24 or 12 hours and close the abdomen as usual. So this is one approach, and this is another approach, that is from the pouch of Douglas. There is a posterior approach. The postpartum uterus is always bulky or large, about 24 weeks. So it is difficult little bit. Pelvic tissue are edematous and congested, and uterus should be exteriorized and held by the assistant. So opening retroperitoneal space through the pouch of Douglas is to be done. The assistant should push the rectum back, and then surgeon should hold the peritoneum and open the retroperitoneal space. The ureter can be seen transperitoneally on the lateral side. Here you can see them. And inserting the finger on the retroperitoneal space and gently widening to the expose to the all the vessels, like vessels. The iliac vessels can be seen through the opening here. You can see here clearly. And then after exposure, you have to see the bifurcation of the common iliac, and then it has to be lifted, and identification is very important, and tying is another one. So this picture demonstrate the vulnerability of the internal iliac vein. What I told was it is just below. So the adipose tissue, when you separate, it is common that the vein can be ruptured. That is a common complication. And then in this picture, you can definitely see the proximity of the external iliac artery, ureter, and the anterior branch of the sciatic nerve. So this also can be damaged sometimes. So these are the various complications which we get: the external iliac vein injury, internal iliac vein laceration and injury, ligation of the wrong structures like ureter, external iliac is very common, and the spasm. It can external iliac artery can go in spasm and thrombosis, injury to the internal iliac artery, and other complications like bladder atony, necrosis of buttock, bladder mucosa. Though they are rare, they are mentioned. Because of the good collateral circulation, the reproductive functions, post-ligation syndromes. So reproductive function is not affected. Menses they return normally, pregnancies occur, and reach term and without any intrauterine growth restrictions, suggest that adequate blood supply after ligation. So these are the few of the literature I searched, and they found that the overall procedure, they found that the complications are less and the reproductive performance is best after bilateral iliac artery ligations. So every practicing obstetrician must know about the procedure. It may be life or uterus saving procedure. So, and it should be tried before obstetric hysterectomy. So, and that is what we teach our students, that they must learn this internal iliac artery ligation and uterine artery ligation perfectly. And whatever the complication we face, they are transitory and rare. And it should be used as a prophylaxis to prevent hemorrhage and to secure hemostasis. We teach them during gynecological surgeries, and then when they are trained, they can definitely use them during their obstetric procedure whenever required. Now, what about peripartum hysterectomy? It is an emergency life-saving procedure which is performed when all other measures have failed to arrest hemorrhage. So it should be assertive and should make early decision for this hysterectomy before the patient exsanguinates. So one should not delay the decision, what we always say. And it is the most urgent. Delayed decision definitely leads to maternal mortality. So decision performing hysterectomy, you have to analyze the situation, evaluate options, whether we can shift, choose, and definitely act on this. Uterine atony and uterine rupture were formally regarded hysterectomy, and they're contributing to the growing numbers for the cesarean deliveries performed over last 20 years. As the cesarean rate is increasing, the placenta accreta and all those things are increasing. Now, for any hysterectomy, the consent is very, very important, and it should be anticipated in some of the cases. Like we know that this patient is having placenta accreta, definitely we have to take the consent. And when it is unanticipated case, the law definitely allows these surgeries if it has to save the mother. So one assistant is required to inform, no, always outside we have to inform and take the consent, and we have to tell them that we have to save the mother. So patient has to undergo the hysterectomy. What about the challenges? Whenever we take the decision, we are always biased and always think of her age, aparity, patient's condition, blood loss, and whether we can do furthermore interventions. So always many times surgeries are unplanned, and the need for hysterectomy or any procedure, it is always go on compounded. The postpartum uterus does not present the same anatomical landmarks to aid the surgeon. So surgeon has to be anatomically perfect. And tissue planes, though they're easy, but they do not resemble their counterparts of non-pregnant situations. So these are the challenges we always face. And also the vascularity. The technique of the obstetric hysterectomy. So clamping, cutting the uterine pedicle first. So first clamp until the uterine arteries are secured, and then suture. So tying these pedicles. So clamp, cut and drop is a common technique what we use for the hysterectomy. Remove the cervix means some people say total and subtotal. There is really sometimes it doesn't matter. But it is very difficult to do total hysterectomy when there is so much bleeding, and there is no necessity unless the implantation of the placenta is on the lower uterine segment. So these are some of the situation. Those are difficult situation what I have faced, and these are the rupture. You can see the placenta previa accreta, and the posteriorly also the placenta is adherent. The studies have shown the bladder injuries and ureteral injuries, which are very common, though less. The ureteral injuries are less. The inadequate evidence examining different surgical approaches for hysterectomy, total or supracervical hysterectomy. So there are less evidences. Thus, the setting of an emergency postpartum hysterectomy surgical approach is felt to be fastest, and safety should be used in these patients. Now, what about traumatic PPH? Here also surgical management is required, like cervical vaginal laceration, vaginal and vulval hematomas, And we know about the risk factors in these traumatic PPH, like instrumental deliveries, when there is a macrosomia or the large for gestational age newborn, uterine rupture, or at cesarean delivery, the lateral extension, or there is a colporexis. Then if the incisions are made too low, not sufficiently curved on the low segment, these are some of the practical things one should know. The incision, which is very small, but once the baby is taken out, the incision definitely gets extended. So most of the juniors, they will be operating, junior residents in the operation theater. So we get many of times lateral extensions, very common. So whenever we talk of traumatic PPH, always repair the lacerations, ligate the vessel stepwise, and always do the hysterectomy if required. This cervical inspection kit should always be there in the labor room. This is a special retractor where it can retract the cervix properly, and the repair of cervical laceration, how it is done. So this has to be also taught, that how to explore the cervix, and if there is, after any instrumental delivery, to explore the cervix, and if there are any cervical laceration, they should be properly secured. Vulval hematomas are also many times we come across, and that has to be drained properly. And if the patient's hemoglobin is too low, many times the complications with smaller hematomas also, the patient comes in shock. And these I will not tackle much, I will not talk much, but many times disproportionate we get the shock. There is external, no bleeding, but there are so many broad ligament hematomas. Then there is hematomas below the level of the pelvic floor and above the level of the pelvic floor. Ultrasound examination, proper examination, clinical examination will also explore that lithotomy position, adequately anesthetized, examination under anesthesia, and always, if possible, it can be drained properly. Local any bleeding points are there, that should be secured, and hemostasis to be achieved. So many times we come across such hematomas. Now, what about the interventions? Interventional radiologists to be called. In uterine artery embolization sometimes may be required, but limiting factors is one is availability of such an angiographyst or radiologist. The facility should be available, or patient should be relatively hemodynamically stable. So these patients can be referred to this uterine artery embolization as well. So I just want to comment that whenever the medical management is PPH is unsuccessful, surgical option should be utilized in a timely fashion in order to reduce maternal morbidity and mortality. One thing. Effective preparation, mobilization of the resources, and organized approach. These are the three things. And evaluation and the surgical management of these patients is very important. The multiple fertility preservation surgical techniques are now available. We should train all the residents, and that should be practiced to control PPH. Even though there are a variety of conservative surgical approaches which can be used in a hemodynamically unstable patient, readiness for definitive management, as I told, is a hysterectomy, which is necessary many times, and one should not hesitate to do hysterectomy to reduce the risk of maternal mortality. So this is the statement by FIGO chair Jerker Legistrand, who says that implementing this approach addressing PPH requires one is facility readiness, supply chain improvement, teamwork, communication, network integration, where staff communicate and collaborate between the facility, and local data used for troubleshooting and improvement. This is very important. And these are the various videos which Dr. Sheila Mane, our past vice president, she has done wonderfully with the model. They are available on the YouTube. and that can be used for training of our residents and postgraduates. So intelligent anticipation, skills supervision, prompt detection, and effective institution of therapy can prevent disastrous consequences of PPH. So one should be acquainted where the medical management should be stopped, where the surgical management should start, and which patient, which surgical management should be applied. That is very important. Thank you very much for the patient listening, and thank you, Dr. Pratik, for calling me for this talk. I also just read about all these things, and just I came across these other sutures, but I don't know. I have not used, but I just read about this Matsubara Yano suture, and different various sutures are available, but we have not tried those sutures. Even they have got sling like sutures and all those things I just came across. Just I shared those sutures now. Thank you very much. And Bhagya Lakshmi, just I want comment, you're an oncosurgeon, so uterines, uterines and all those vascular pedicles, they are just a tip of your fingers. So you must have so many postgraduates and so many malignancies you have handled. So you are the better person. And you can give me tips and tricks about how to handle the surgical management of PPH. Yes, thank you.
Thank you so much, Dr. Vidya. I think you have done a wonderful job. But at this juncture, I think, and all the anatomy, everything you have shown so nicely. I think we should make it a point that when we are doing normal cesarean section also, they should peep into the anatomy a bit, because whenever they would really need it, maybe they would not be able to find it. So I think
Yeah.
peeping into the retroperitoneum even during normal cesarean section will go a long way. But then we need to develop the skills of our youngsters. So I think webinars are doing a huge job, but then skill labs and hands-on training. So the skills have to be transferred. So I think through this platform, I can request Mox and Foxy to have some more of this hands-on training program.
I just
for our
this
younger-
practical obstetric committee is doing that internal iliac ligation, but unless
Yes,
I feel that feeling and that dissection should be a physical one only.
Yes,
Madam,
yes.
can I
So
request you to please stop screen share?
Yes, I will.
We are delighted to welcome Dr. Kiran Kurtakoti, sir. He is our Vice President of AMOX, and sir was busy in a cesarean and he couldn't join us on time, but he was there just in time for Dr. Vidhya Thobbi's talk. He came in just at the beginning. Sir, your comments, please.
Yes, at the outset, Pratik, heartiest congratulations to you. You have been a webinar person right through COVID times, and thank you for that. And really, it's a warm welcome from AMOX platform to Dr. Vidya. Vidya will be taking over as Kasoga next year as the president of Kasoga, and I'm sure I've already spoken with her that AMOX and Kasoga will have a good sort of a joint venture in the next year. So yes, I have heard the entire talk of Dr. Vidya, fabulous talk. And I would like to point out here that definitely all our postgraduates must learn the art of uterine artery ligation as well as the internal iliac artery ligation. Now, what is happening is we have a lot of courses of retroperitoneal dissection laparoscopically, where we are taught the endometriotic approach as well as the malignancy approach. But there are no courses as far as the open ligation is concerned, which is more simpler and more easier. So probably if there is a lot of hue and cry, you should not ligate the normal internal iliac, then probably you can place a shoestring knot which can be removed. So the students, the postgraduates, they can just pass in a mixture, tie the knot and remove the knot. That's a shoestring or shoelace knot, whatever is removed. So that can be taught to all our PGs. Now, what we are doing is for all high-risk patients that we operate for, especially for C-section, by default, we ligate the uterine arteries, not from the front, but from the back. So just above the uterosacral, wherever there is a transparency in the broad ligament, we just take a suture, bilateral uterine artery ligation, and the patients do very well. As a matter of fact, if at all you see these patients post-operatively, then they do have less amount of lochia. So probably that could be one of the way by which anemia can be prevented, because all these girls, they do not take iron and calcium post-operatively or post-delivery. They do take it antenatally, but not postnatally. So I think that could be one of the research or a thesis topic or a practical thing to do for our patients. So, I mean, that's all. And Dr. Vidya, if you don't mind, if you could share your presentation, we can definitely request our web coordinator, Dr. Ajay, to put it on the AMOG's website. So, it's a very nice presentation that you have done, especially the supralevator and infra levator hematomas, the pics that you have shown. Very nice, and would be a great thing for our PGs also to learn. So thank you so much.
Yeah, I will definitely share. I will just modify because I was not well, so I did not do it well. I think I would have put some of the references and all those things. I could not do that, but I will do it nicely. I will edit it and I will definitely send it.
Yes.
Thank you, ma'am.
Dr. Leela, we
Appreciate
will be shortly coming to you also, because we would want SOGOG participation also in the next year. I will talk to you one personally later on.
So we have a few questions which have come in from the audience. This is from Dr. Rekha Deshmukh from Thane, and she's asking whether, just like Carbopros, we can give carbacin, that is carbetocin, intramyometrically in PPH. So that's not something which is recommended. The recommendation is to give it slow IV over 1 minute, and that usually takes care of more than 90% cases of primary PPH prevention. The next question is from Dr. Vaishali Raut. She's from Jalna. She's asking what is the most common cause of PPH these days. I think Dr. Leela Vyas mentioned it in her presentation that more than 50% of cases is atonic PPH. But more significantly, more than 50% of those atonic PPH, we cannot predict antenatally who is going to develop the atonic PPH. So prevention is the best cure, and we have to be prepared for atonic PPH in any patient. Most commonly, the patients who land up with PPH are the ones where you don't anticipate postpartum hemorrhage, where you are ready, your senior most consultant is there, anesthetist is there, intensivist is there. Nothing happens in those patients. They are absolutely fine. But when you're least prepared, that is when these patients will come into your
so
precautions using injection carbetocin.
So I think
Yes, ma'am, go ahead.
Every patient means you think of that. It means every patient can have PPH and we should stop it.
Absolutely.
And
Absolutely.
definitely all the techniques, which one point I just want to add that Vidya ma'am has explained very nicely each and everything. Pratik, you all can take this task that we make them to learn something about the obstetrics. You are doing anything but obstetrics. If you are OBGY, MS, DNB, or any of the degree DGO, you are there. The one or other day, the obstetric patient will come to you. And if you are a big surgeon, big endoscopist, they will think of that you are a big doctor. You have to, but you can tackle a most serious patient. So they should not leave this thing and make this understanding. And with them, ma'am, we have to take this also task that to make them learn this thing. And Bhagya Lakshmi is also there, and Dr. Kiran has said that very nicely that it is to be explained each and every one candidate and make it as a compulsory for the every student to do this. As cesarean karke nikalte hain, one at least internal lag ligation, they should see that in their tenure.
Yes.
Thank you, ma'am. Dr. Swati Agarwal from Sikar is asking what is the minimum repetition time for carbetocin, and the simple answer is that it's not recommended to be repeated. It's only to be given single dose over 1 minute slowly, and if that fails to control, which is rare, then you need to go to second line and third line agents. Next question is from Dr. Shashikant Bawar from Malegaon, and he's asking what is the incidence of developing hypertension after carbetocin. The simple answer is so far we have not had any reported incidences of hypertension from literature that I can recall, but we will go back and we will check whether there is any isolated case report. The vast majority of patients have absolutely no issues at all. We have more than 1,000 people who are logged in to today's event, and they have watched two fantastic talks from Dr. Leela Vyas, our past Vice President of Foxy, and Dr. Vidhya Thobbi, soon to be Vice President of Foxy and President-elect of Kasoga. Thank you so much, both of you, for being here. Any closing remarks before I present the formal vote of thanks? Please feel free to go ahead and speak now.
Yes, this is to be a PPS to be in your mind, and वो कहते हैं ना, you always think of that. These patient, any of the patient is going to deliver, she can have. So readiness is must. Your mindset like that to be a positive that we can save it.
Thank you, ma'am.
Thank you very much.
Obstetric is a bloody business, as everybody tells. But the PPH is evergreen topic, and always we discuss medical management and surgical management. Even then, we are not bringing down the PPH incidence. So, as Kiran was talking, the anemia and the risk factors, at least we know that PPH is not preventable, and in any patient, PPH can occur. But at least assessment of risk factors and be, as Leela was talking, be prepared in at least those risk patients. That is the answer. Thank you very much.
Thank you, ma'am. Kiran sir, Bhagyalakshmi ma'am, any closing remarks, please?
Thank you. I have already spoken. Thank you.
Thank you very much. So at the end of today's program, I'd like to present the formal vote of thanks as the convener. Today's event was centered on postpartum hemorrhage, preventing maternal morbidity and mortality. I'd like to express my gratitude to the AMOG's office bearers, Dr. Rajendra Singh Pardeshi, our beloved President, Dr. Sujata Dalvi, our Secretary of AMOG's, to the ICOG office bearers, Dr. Lakshmi Shrikandi, Chairperson of ICOG, and Dr. Ashok Kumar, Secretary of ICOG, for the ICOG credit point, not just for this event, but all the other events as well. Dr. Kiran Kotukoti, sir, our Vice President of AMOG's, joined us in person. Thank you so much, sir, for taking time out from your busy schedule and being here despite your OT. Dr. Bhagyalakshmi Nayak, our Governing Council member of ICOG and also soon to be, I think, Vice President of FOXY. Dr. Vidhya, you have keen competition. Thank you for both of you being here. We had two lovely talks by two excellent speakers, Dr. Leela Vyas and Dr. Vidhya Thobbi, who comprehensively covered both prevention as well as management, medical as well as surgical of postpartum hemorrhage. It's a very huge topic and they did fantastic justice to it, especially considering the newer molecule of carbetocin, which has now been launched by our academic partners, Blisson Pharma. Their molecule is not only heat stable, but also available in a pre-filled syringe form, and it's a patented formulation. So thank you, Blisson, for helping us conduct this event and taking it countrywide with the aid of Science Integra. Subbu, Ganesh, Sana, thank you for doing fantastic work behind the scenes. And most importantly, to the audience, 1,000 plus of you from all over the country who have logged in to watch this event. Until next time, goodbye, God bless. We hope to see you very soon in a couple of weeks, where we'll be talking about another important topic as far as high-risk pregnancy is concerned. Thank you for now.
Thank you.
Bye.
Thank you. Thank you.
You can take us off air.
Thank you.
Thank you.
Thank you so
Vidhya
much.
madam.
Thank you so much, Dr. Pratik.
Thank you, Bhagyalakshmi.
Thank you.
Bye.
Bye.
Thank you all. Thank you.